I did this as an echo a while ago, and it's what we came together and discussed from our Alliance conference. And for our purposes, it's about, I'm not going to go through the whole thing, but we're really going to talk about what we're trying to measure in terms of quality and quality improvement in adults. And one of the goals is to create what we call an annual visit, or one big visit a year. So we're going to call it the annual visit. And then everything else will kind of be follow-up visits. And the annual visit will be with me. And then we can work on the follow-up visits, just dependent on the patient and who they need to see when. And so we're going to use Granddad. So we already have all of this information in Granddad, but the way it is right now, we can't automatically input it from Cerner to Granddad. And actually, Kelsey was just here, and that's what we're going to be able to do. So we're going to actually be able to automatically input it, which will save time significantly for our coordinators. So it'll be in two places. It'll be in our Granddad notes, but it'll also be as an annual visit note where you can look and see their last eye exam and their MRI and all that stuff. So this is just a picture of the centers that we did, and we put all this together as a consensus recommendation. And what that meant is that we took all the people's opinions who are part of the Alliance and said, what do you think is best practice? Because there's so many of these things that we don't have data for. We have, as you've heard me say a zillion times, right? We have a lot of anecdotal data, but not a whole lot of hard data that was tested in randomized controlled trials. And so we made sure when we put this together that we didn't go against the guidelines that exist, but that we just put some things into terms that weren't there. So like, for example, this MRI question, you need to get one MRI as an adult. Well, what does that mean? When should you get it? And then when should you repeat it? So those are things we just wanted to put into paper that we could then say a schedule of events. What should a patient have annually? What should they have more often? These were the different ones that we looked at. We did pediatric screening, adult screening. We talked about transfusion recommendations. We talked about how we implement our care plans. And we talked about another whole subject on what is a high-risk vaso-occlusive crisis. So we're going to be able to stage crises that, at least for a little while, we think will help triage, who needs to come to UAB and who doesn't. Those are our goals, because as you can see, with our hospital so full, it makes things complicated. So here we're focusing on our adult screening recommendations. And quick reminder that screening means asymptomatic screening. So if you come in and you say you have shortness of breath and we do an echo, that's not screening, that's diagnostic. That's saying you have a problem and we want to do a test to evaluate the problem. And a lot of people get confused between those two things. So screening means we're just checking to see if there's a problem that we don't see. This is the metamorphosis that I always talk about our patients go through as they become an adult. So one of the first places to start was transition of care. So we need a formalized structured transition that has a handoff. We do all of those things here. We need to have a transition coordinator on each side, so a pediatric one and an adult one. And then I think the biggest thing that we're trying to put into true recommendations is a follow-up touch point 2 weeks or 4 weeks after that initial visit. So the first time they see us, they don't wait another 3 months till they see us again. That they see us 2 or 4 weeks later, even if it's just a phone call or a televisit, just to say, making sure everything's okay, you got your meds, you don't have any new questions, all of those things. And so these are all things that we're going to put into a formalized note at transition. We have a pretty formal note that we use on the ped side, so we're just going to make it on the adult side that says these things. Immunizations. This was a pretty hot topic. And for the most part, we decided that we couldn't decide on a lot of things and we needed an infectious disease expert. So we're going to focus on pneumococcus, influenza, and hepatitis B for vaccines for now. There's great debate as to meningitis. Who needs those vaccines? Does everybody need them? Do they not need them? There was so much debate that we didn't have time to cover that. We're also talking about Hep B immunization status. Dr. Klein already does a phenomenal job of checking this, but making sure that we check it in everybody if they've never had it checked, and boost as needed. And then making sure we're doing Hep C screening annually along with HIV screening, which should be on here at least every year if people are transfused within that time interval.
Question, Dr. Cantor, for the Hep B, so if a patient in their immunization registry already has 3, I'm not checking a titer, because we had talked about, and you said sometimes their titer is not going to be positive.
Correct.
Is that okay?
Yes.
Okay. So keep the same practice I'm doing.
Yep.
Okay.
Most people weren't doing that, so that's why it's there. And it's not, we're going to move it to a note where we can capture that annually that it's been done. So then red cell genotyping. So we do this, but not everybody does. We want to, and this is a one-time test. So the difference between genotype and phenotype of your red blood cell. When we're checking for antigens and antibodies, that's called phenotyping. That's saying, how do your red blood cells act in the environment? I'm going to explain this in terms of gender, which I always think we need to rephrase what a genotype, a genetic gender and a phenotype gender. So you are born 99%, 99.9% of the time, you are born as male or female with the male or female appropriate gender, with the appropriate private parts. Let's go with that. Organs. That is your genotypic gender. However, you may decide later that you were born male, but you're female, right? We know that. And so your phenotype is how you act in the environment. Just a way to think about it. Red blood cells similarly actually have a genotype. So we can read, if you will, off a red cell what their antigens are. And it's much more specific than what we can do by phenotyping. So, and it's one test. You never have to do it again. Your genotype doesn't change. So we want to make sure that everybody has at least a single red cell genotype once in their lifetime. Now, if they had this in pediatrics, we don't repeat it in adults because, again, it doesn't change. Right now, they're not doing it at children. So for us, we're only doing it here. But long-term, this is where the whole field is going. So it's just one of those things that we want to put in our annual visit that says, yes, it's been done, no, it's not been done, and we're going to do it. So iron overload, we talk a lot about this. We talk about ferritin, and basically the consensus was in people who are getting transfused regularly, so chronic transfusion therapy, they should at least have a ferritin checked quarterly, because otherwise you can't see the overall, the overall pattern of that ferritin since there's so many ups and downs. But if they're not getting transfused, then we don't need to check it except for once a year. One thing we're not doing that we have to add is transferrin saturations. We want to make sure we're checking those every year. And that's because transferrin saturation actually can help us look for iron deficiency, which sometimes we forget to look for in our patients. And of course, remembering that ferritin should not be checked in the acute setting because it's not useful. Health maintenance, this is what this visit's going to be. It's a strongly recommend an annual extended comprehensive visit that really details a lot of this information. This should be an hour-long visit. We'll have a plan where we prep for this visit in various ways. And this is something where we can't just suddenly snap our fingers and do. We'll have to slowly bring it into our practice plan. And it will make all the follow-up visits easier, but it will also make tracking health maintenance easier. These are the labs that need to go into that annual visit, and then at least a PHQ-9 annually, which again is something that Dr. Klein has been doing, but we want to incorporate it for everyone. Neuro, this is that MRI. So for SS beta 0, they recommend an MRI once in a lifetime, consistent with ASH guidelines. And we're adding to that as soon as possible when they get to adult care. That's when that should happen, with the exception of if they've had one in the last 2 years in pediatrics and if that was normal. And then we want to add in the necessity of an MRA. So MRI looks at brain tissue, MRA looks at the arteries of the brain. And that's really important as people age because we know they're liable to get aneurysms as well as the potential for stenosis, that we should be referring to neurosurgery if we see significant stenosis or aneurysms. So then the question is, okay, if we see silent infarcts, what do we do? And the discussion, I didn't always agree with this, is that we should refer everyone to neurology. My question is, what are they going to do about it? But whatever. We should repeat that MRI at least every 1 to 2 years if we see silent infarcts. if we don't see anything, and this MRI and MRA are totally normal, there is no guidance on repeating it ever. So you would only repeat it if there's new symptoms. And then you should always, of course, be discussing secondary preventative options such as transfusion, stem cell transplant, as per ASH guidelines. Whenever possible, especially when we see silent infarcts, we want to do neuropsych and functional evaluations.
Dr. Cantor, something I learned that actually fits well with your as soon as possible is that Donna on the Peds side, Murda and her group, they can do neuropsych evals for Medicaid patients up to age 21. So if they get their MRI at say 19 and it shows silent infarcts, we can get it covered. We can get the neuropsych testing covered over there. But
that's really cool.
Yeah, if they're over 21, it's no go. They do need a EPSCT, which is like a well visit, but this would be considered like a well visit, and we could fill out the Medicaid form.
That's something we should also put into our transition recommendations.
Yeah.
Is if they're already 20, let's get it done there before they come here. Because they're not routinely doing it, meaning they're at Children's. Cardiovascular, you would think echoes were opioids by how much people are passionate about what we should and shouldn't do with an echo. It is hysterical to get Sophie Lanscron and Liz Klings in a room and let them argue about this. It all goes down to the difference between screening and diagnostic. So the basic, if they are totally asymptomatic, then you should not be screening with an echo. You should be screening with a quick question. And we're going to have a toolkit that has these questions. So it's basically, do they have problems walking 5 blocks or more? This is not problems with pain. If they say, yes, my hip hurts, that's not the question. Is do they have shortness of breath or, significant tachycardia that limits them? Do they have shortness of breath or trouble breathing at rest? And do they have unexplained pedal swelling? And I think are the 3 different things that are going to be on that toolkit. But if they don't have a positive screen, they don't need an echo. And so this is a change in practice from what was done at UAB before I got here. But the problem is we do a ton of echoes that don't mean much and that are probably not necessary. And then sometimes we repeat them. So it gives us a little bit more direction. And then otherwise, we try to do these even if they are for diagnostics, so shortness of breath or whatever, we also want to make sure we're doing them at baseline. If they're done in the hospital during an acute crisis, we need to repeat them later on because we know that things like TR jets, which is the measure we look for that kind of tells us whether somebody could have pulmonary hypertension, we actually know that that's going to be abnormal during an acute crisis. And so measuring it only during crisis isn't helpful. You have to measure it at baseline. So what about all the other organ systems? So pulmonary function testing should really go into that echo workup. So there's a lot of discussion about echoes, but not enough about PFTs. So when you have shortness of breath or other complications, you shouldn't just be doing an echo. You should also be doing PFTs. But you don't need to do them in everyone every year by any stretch. It should only be for individuals who have recognized restrictive lung disease or for those with symptoms. Eye exams are well known. We need to do those every year. Dr. Klein and I are working on a project that would allow us to actually do a retinal screen in clinic, which would be amazing. And that would really, so it's got a lot more to come, but stay tuned because that'd be really cool. Yearly proteinuria screening. So most of us feel like you need at least Q6-month albuminuria protein screening. But at least every year it should be required. So a hearing assessment is not something that we've done before. It's still really discussed as to whether they need a formal audiogram, but they should be at least asked, do you have any problems hearing? And if they note that they are, then we need to make sure they get referred. And then we're putting this into the paper knowing for sure that obviously it's not true right now, but dental caries should be considered a complication of sickle cell disease and routine dental exams should be covered by payers. Everybody should go to the dentist once a year. I'm sure that all of us are perfect at going to the dentist once a year. But certainly it's something that a lot of our patients aren't able to pay for. And so we want to make sure we put that into our paper as something that should be covered.
Hey, Dr. Cantor, two questions for the PFTs, because I do end up ordering those some. You're doing the full PFT with DLCO, correct? Like we want it all.
Yes, and 6-minute walk.
And you can get that done as part of the PFT. Like
yep, it's on the same order form. Make sure you're using the power plan.
Okay. And then for the hearing assessment, I feel like I may have mentioned this one. So in peds, we have like this like little box, that we do the routine every year. We check their hearing. And it's super easy. I mean, it takes longer in kids. In an adult, it probably takes less than 60 seconds. They put the little headphones on, they raise their hand if they can hear it. But that could be something that could be done. And I gotta imagine they're not that expensive. And UAB may have some lying around, honestly, that we could do at that yearly assessment. And if that's abnormal, then they would be referred for a formal audiogram.
Yeah, I think that's a great idea. And maybe we'll put that in with our eye screening assessments. I don't know. We'll have to look and see how much that's been used in adulthood, just in general. And if there's any validation in it.
So we use it, it's part of the Medicare, like when I used to do Medicare, they're like annual visits that Medicare required. That's what we did. So I think there is in like, at least Medicare population.
Yeah. I mean, as long as there's data that suggests that it's adequate. Yeah, that'd be great. What about bones, endocrine, GU, skin, and GYN, yearly vitamin D testing with appropriate supplementation? Most of us feel like you need to do at least twice a year because of the variation, and that, as you'll often see, our patients will get into the normal levels and then 6 months later, they'll need it again. There's a lot of discussion about bone testing. And the real problem is when we see something like, osteoporosis or osteopenia more often, not osteoporosis, but osteopenia, are we going to do something about it? So the other key about screening is you don't want to screen unless you can react. And so it was decided that it should be age appropriate DEXA scanning. So not DEXA scanning when they're 25, waiting and doing it as you would for a normal adult, because the data is not good that there's anything for us to do at this point. Recommending against screening for asymptomatic avascular necrosis. So that's really important. There's a lot of people who randomly I didn't know this actually, we're doing hip x-rays just because. And again, if you're asymptomatic, no one's going to do anything about that avascular necrosis. Unfortunately, we don't have any interventions that work. So there's no reason to screen for it. But if people are noticing significant abnormalities in their joint mobility, then that's something we would do. Making sure we ask about priapism and erectile dysfunction. If we're not asking, we often won't get the answers. So you have to ask. And it's amazing how often some of our, especially younger men, as you might imagine, who are like, yeah, I don't want to talk about my penis, will tell you about it. And it's so interesting because women have no problems talking about their menstrual cycles or other things. But, men really don't want to talk about priapisms and erectile dysfunction. So you have to ask. And then performing detailed skin exams, especially looking at the lower extremities, looking for changes that could identify low flow or abnormalities in blood flow, specifically looking for venous stasis. And then, of course, ensuring appropriate gynecologic care. So I'm going to stop because that was the basics of what we're going to do. And as I said, this is a work in progress, but I think it's actually going to be tremendously helpful for our practice. Both that we're going to codify this in a way that it's done once a year and we'll check it off when patients have done it, but also that then it will make our colleagues in Granddad, this will be so much easier for them because it'll just automatically input into Granddad. And then the other part of this is within Granddad, we have a health maintenance form that we can print out that actually says whether or not they've had these things done. So you can then look at it and just say, oh yeah, it's done. So we're going to make those available. And Rachel, those should be really helpful for you too.
Will Granddad pull from Imprint or will we have to manually put in all the vaccines?
We'll have to probably manually, so we can into Impact.
So yeah, so there is a way to pull Imprint into Impact, but it's,
yes.
I don't know if Kelsey is here, but it's not great. But it's better than nothing. But it does miss some. But so if it can do that, then it can pull into Granddad from.
Yes. So we're going to create this annual note that will pull the Granddad. So as long as we put it into that note, it will pull. And Kelsey's, that's why she was here waiting for me this morning.
Got it. Okay.
I wasn't.
But I'm not doing that manual pull thing because it's not as accurate. So I just go into Imprint, but I can start doing it so that it will already be there for because I'm looking at the vaccines anyways. I can pull it, but yeah, I can do that.
And it won't be for all of them right now. It's really going to be focused on pneumococcal flu and Hep B.
Right. Yeah. But the Hep B, most of our patients our younger patients have all gotten their series as a kid. So if we don't pull it, we'll think that we're deficient, but we're not.
Cool. So we'll make it so it, and I think we should be able to make it so we don't have to manually do it. We should be able to make it that the note pulls it for us. So that should make it easier. All right.